Will now be recorded.
So I'm Paola Angelini. I'm one of the pediatric oncologists at the Royal Marsden Hospital. And thank you everybody for your patience with my audio. We're going to talk today about abdominal masses. And first of all, well, you have already seen this slide. The goal of this presentation is to never ever see another paper like this, which show that evidence for delay in diagnosis of venous tumor in UK compared with Germany. This was published by Professor Pritchard Jones, an international leader in renal masses in children, who showed how pediatric patients were diagnosed with larger and more advanced tumors compared to German patients in a larger Europe-wide study. Fortunately, the survival was comparable, but nevertheless, we want to improve this. And to jump to the conclusions, so that everybody knows where we are going, we really also keep a really high index of suspicion for abdominal masses, which are very hard to detect sometimes, or to suspect. And if you have a puzzle, all the puzzle must always fit in and be completely understandable, with no leftover pieces. So how do patients who could have an abdominal mass present? The first aspect of is the history, as usual. Patients can be completely asymptomatic, and an abdominal mass can be an incidental finding from the parents or family members who appreciate a hard spot in the abdomen of the child. Okay. Other times, a very common symptom is constipation or diarrhea, so a change in the bowel habits, which lasts for 1 to 3 weeks. But I would say any change which doesn't respond to medical treatment. There are of course a lot of children with constipation around, and a lot of children with diarrhea. How to discriminate those who could have an abdominal mass? Through physical examination, we will see. Per rectum bleeding, of course, can be caused by fissures and constipation, but should always be looked at with attention. And an abdominal mass on the left, the egg fossa, can of course be a focaloma, but it should not be on the right side. And we will talk about a case which presented exactly with a right-sided mass and constipation, and was investigated for a long time for constipation. Abdominal pain is very common. It's of course a very common symptom in the pediatric population, and it's completely aspecific. So it's unfortunately not specific of one tumor, but of any abdominal mass. Fatigue, malaise, very common, in particular for a young child. The parents will say, oh, he just doesn't do anything. He sits down on the floor, doesn't want to play. This is not normal in a child. This should always be a sign very concerning, although aspecific. Fever, again, very aspecific sign, but concerning. Anorexia and weight loss. I'll give you an example in a few minutes. Unexplained weight loss, the child who stops growing and starts having loose trousers, the child who just doesn't want to eat anymore. Vomiting, again, very specific sign and very specific symptom. Could be a sign of brain tumors also, could be a sign of GI disease. It can be caused by compression from an abdominal mass. It has to be investigated. Limp or refusal to walk, again, it may be just because the child feels tired. It can be because of pain. And the symptom is usually intermittent. Pain, whether it is abdominal pain or bony pain leading to a limp and refusal to walk, or regression and loss of milestones, is often intermittent because the pain is not continuous. So the child will go back and forth in walking or not, limping or not, and pointing at constantly different points of pain. Urinary retention or dripping. This is a real red flag, not only for an abdominal mass, but also in particular for spinal cord compression. A change in the urinary habits. How do we catch it in a child who is still not dry? It can be a change in the pattern of changing nappies. It's helpful to ask the parents if they ever have a dry nappy. And sometimes instead there will be parents who present with urinary retention, saying that the child does not pass any urine for several hours. It's always a very concerning sign. Bleeding per rectum or per vagina. And hematuria is often associated with renal masses. Nothing of this is specific, but all of these are symptoms which require further investigation. So then you're going to examine your child. You may have an abdomen which is distended, but you may have actually an abdomen which is not distended and looks actually normal. If it is distended and there is a large mass, occasionally you can have a vascular reticulum from compression on the IVC and the development of an accessory vessels. You can have ascites into more advanced cases. It doesn't need to have a long history. Some tumors present with a very short history of rapid evolution, and you can have ascites with a 1 week history of some abdominal pain and constipation. So a short history doesn't mean that it's not reassuring in any way. It doesn't mean that there cannot be a very serious and concerning underlying disease. Hemorrhagic manifestations, this will speak more for bone marrow involvement, of course, but it would give you an idea of what type of disease could this be. Annus patulus, let's examine the child comprehensively, including the genitalia, to look also for genitalia malformation and the anus. Annus patulus, of course, is another big red flag for spinal cord compression. Vital signs. The blood pressure is often elevated, in particular in neuroblastoma and venous tumor, with different mechanisms. From neuroblastoma patients, it's the compression onto vessels and onto renal vessels often, which causes to increase the blood pressure. While for the renal tumors, it's more related to renal dysfunction. Heart rate, respiratory rate. Sometimes you can have tachypnea because of this mass occupying space in the abdomen, so that there is splinting of the diaphragm. Urine output. Is the child still passing urine? If not, is there a true urinary retention with a globus, or is it just a child who is emaciated, is not drinking, is in poor general conditions, and is not maintaining a good urine output? Weight and height will help you. They may not help you actually immediately unless the child is so cachectic that you will see a small child by age. But they may also point at underlying germline conditions. Hemihypertrophy, so general physical examination of the child. Remember that in children we always need to pay attention to possible underlying and yet undiagnosed conditions. You may or may not at this point suspect a mass. Okay, and so most likely you're going to require some blood tests. If you have a child who has presented to you with let's say 1 or 2 weeks history of constipation, some abdominal distension, low energy, and you're not quite 100% sure, but you might have felt a mass. So these are some very general blood tests that we will always ask you to do as upfront. The full blood count. The full blood count, we always think of full blood count for leukemias, but actually many times it is abnormal with abdominal tumors as well. In different ways. There may be malignancy which is involving the bone marrow and causing a deficit of production, and so you will have the full-blown picture of thrombocytopenia and anemia. You can have anemia from chronic disease in many malignancies, like in neuroblastoma, Ewing sarcoma, but also in advanced malignancies, like advanced with tumors. Many sarcomas will cause anemia from chronic disease, which can be hard to discriminate from actually an iron deficiency anemia in the toddler. Clotting. You always do the clotting thinking of potentially you may need a biopsy and so forth, but you're also looking at potential acquired von Willebrand disease. This is typical of venous tumor. It's transient. It will give you, it's not only important from a practical standpoint, but it will also help you in diagnosis. Renal function, including electrolytes. And let's remind us that we always often have hypercalcemia in mesoblastic nephroma, which is a benign disease of the kidney, typical of the young child. LDH is a very aspecific tumor marker, But I would say that we do use it not only for prognostication, but also to help us orient our differential diagnosis. You have lower LDH in a venous tumor, for instance, and much higher LDH typically in neuroblastoma or in sarcoma, if they're aggressive sarcoma. Liver function, as to say, is almost invariably normal. We do it anyway. Okay, and then tumor markers. Okay, so tumor markers are substances that are either made by cancer cells or by normal cells in response to cancer. Some tumor markers are specific, while others may be present in many different types of cancer, like the LDH, as we just mentioned. I'm just going to go through the most common tumor markers that we would often request at the presentation of a new abdominal mass. Okay, alpha-fetoprotein is increased in hepatoblastoma and germ cell tumors. The big problem with the alpha-fetoprotein is the age dependency. So the normal range, I'm going to show a frightening and really scary slide. The normal range really varies with the age. And nobody is expected to remember this, including the oncologist, but just to be mindful of how variable is the normal AFP level depending on the age of the child. It settles after the age of 2 when it reaches the normal adult range. Beta ACG, also very commonly requested, is increased in germ cell tumor, in particular in choriocarcinoma. And it will direct us not only towards a specific diagnosis, but also towards specifically choriocarcinoma, which requires brain investigation for staging. So if we start having an elevated beta ACG, that will affect the way we stage the patient in the presence of an abdominal mass. And then the catecholamines, in particular HVA and VMA. Again, I put on my slides the metabolic pathway, which leads to adrenaline, noradrenaline, and then to HVA and VMA. Practically speaking, we routinely request for any abdominal mass urinary HVA and VMA on a urine spot, with some attention which needs to be paid. I'm going to skip this to complicate the slides. Either you do a 24 hours urine collection, or you need to do an HVA creatinine ratio and VMA creatinine ratio. And there is some food which can actually give false positives. Now, some are not of pediatric interest, like beer and red wine, but some others, like chocolate and chocolate in particular, banana and citrus fruit, are of interest. And as well as some antihypertensive drugs. So you may have the child who presents with high blood pressure and abdominal mass, and you may need to consider which antihypertensive you want to use to avoid the false positive, or in this case, false negative for the HVA and VMA urinary. There is a variety of others which are less commonly used, and which would be requested specifically if there is a particular suspicion, like if it is an viral mass, we would usually require inhibin or CA125, but there needs to be already quite an advanced suspicion of a specific tumor type to request those. As well as for thyroglobulin in cases of thyroid malignancies, exceedingly rare in children, or alpha osteosarcoma, which are all out of the scope of today. Okay. Then I'm sure you all will want to ask for some imaging. We're talking about abdominal mass. So I put down 4 types of imaging, which are the most commonly used. Abdominal X-ray, really it will not give you a lot of information. You may see calcifications, which are frequent mostly in neuroblastoma and much rarer in the other tumor types. You would probably be your first investigation if you have a child who is constipated persistently and you want to assess if your X-ray is compatible with constipation or if there is any other concern. Abdominal ultrasound should be the first test if we suspect an abdominal mass, if we have palpated an abdominal mass. CT, I don't really want to see CTs anymore. CT exposes the child to radiation, and there is more and more evidence that exposure to radiation into younger age will increase the risk of leukemia and other tumors. MRI is our favorite type of cross-sectional imaging. Now, am mindful that often children will require in general anesthetic to have an MRI, and that the capacity for MRI is limited in many trusts across the country. However, this should be our aim. Okay. Any questions so far? Otherwise, I'm going to go through some pictures actually. All right. So this is obviously CT scan, not an MRI. This was a 13-year-old girl. She presented with about a month history of severe bone pain, which we all felt probably was much longer, her history, because she had weight loss. She had a weight of 35 kilos at presentation. A few months later, she was up to 42. So we suspect that she may have actually sort of hidden from the parents the extent of her pain. She came with a very extensive pain migrating, in particular to the spine, the hips, the legs, and this mass. Now, this mass is a very typical suprarenal mass. As you can see, it was a 10 centimeter mass. Suprarenal and paravertebral. Now, the CT scan does not allow you to have a clear visualization of the spinal cord, but you can see from the axial view that there doesn't seem to be any involvement, intracannular involvement, and this was indeed the case. There was not. So what would be your differential diagnosis for this, if somebody wants to type or advance some hypothesis? Somebody saying venous tumor? Other possibilities? Neuroblastoma? All right. Other possibilities? More votes for VIMS. Anything else? Neuroblastoma. So far we have 4 for neuroblastoma, 2 for VIMS. Pheochromocytoma, very good. We have another pheo. Sarcomas. Excellent. Krauser-Meyer sarcoma. Okay, excellent, absolutely excellent. Thank you so very much. So I'll give you a few more information. She came with a normal blood pressure, but the interventional radiologist actually declined to do the biopsy initially because of the very rounded appearance and clearly clearly a suprarenal mass in a 13-year-old. Now, neuroblastoma, the median age of neuroblastoma at presentation is about 22 months, particularly for a metastatic disease. Now, because of the extent of the pain, we were assuming that she would have bone metastasis even before doing the full staging. But the median age at presentation is 22 months. So by age, she could have been a pheochromocytoma. I will also add that she comes from Peru. Family comes from Peru, and in South America you have a high prevalence of a specific mutation of TP53, and so we were suspecting at some point, and the family has a big family history for cancer. So at some point we were suspecting pheochromocytoma. However, it's incredibly unusual that metastatic pheochromocytoma presents with normal blood pressure. And actually, the more we dug into the literature, the more it appeared that it's about less than 2% of the metastatic pheochromocytomas which do not have elevated blood pressure. So what we ended up doing was we staged her, but with a MIBG scan, which showed a large, very extensive bone dissemination. Now, and in that way, we restricted our differential diagnosis to tumors which are MIBG positive. So pheochromocytoma versus neuroblastoma. Venous tumor, I'm going to show you later a venous tumor, but we had excluded a venous tumor because of how this tumor sits on the kidney rather than originating from the kidney. And I'll show you later a venous tumor. You will clearly see the difference. Okay. Rhabdomyosarcoma, this site would be an unusual site for rhabdomyosarcoma, which more commonly arises from bladder or prostate. So once we had also the MIBG scan, we were left with pheochromocytoma versus neuroblastoma. And we ended up doing a very extensive investigation of tumor markers with plasma metanephrines and urine HbA and VMA, and the plasma metanephrines were not supportive of a pheochromocytoma. So we also ended up giving her an alpha blocker despite the normal blood pressure, because this would have been the preparation for surgery in case of a pheochromocytoma. Pheochromocytomas have a really high risk of malignant hypertension during surgery. The manipulation of the mass causes a release of catecholamines, adrenaline and noradrenaline, which can cause incredibly elevated blood pressure, and so requires management in a center with a specialized cardiac anesthetist. I'm just going through the answers of people. A teratoma would not have given metastasis, and this child came with very compromised in general conditions and with a lot of pain. So to summarize, pain, compromised general condition, but for this mass, the main differential diagnosis were pheochromocytoma versus neuroblastoma, and it ended up being a neuroblastoma. Neuroblastoma, as we said, median age of diagnosis 22 months. It can affect teenagers, and typically it has a very different clinical course in teenagers with a disease which is refractory to chemotherapy and which is less rapid in evolution, but almost invariably fatal. This child is currently undergoing treatment. Okay, great. How about this one? This one is a 3-year-old. This child was a 3-year-old who presented initially to the GP with limp. The mom reported, and she was doing it indeed. She would lift her leg with her hands and move it in order to walk. She definitely reduced her walking activity, her walking in particular. She remained playful. She remained with a good appetite, good overall conditions, no weight loss. But she was just limp and used her hands to lift her leg. So she was investigated for arthritis, for hip arthritis, and then she had an MRI of the hips, which showed multiple bone deposits. She was referred to Tumour for this bone deposit, and then we got a referral coming from Tumour because they felt that this child needed abdominal investigations and to look for a primary tumor, and that MRI picture was very suggestive of a mass. So I see some people are giving their ideas. I see Wim's tumor and I see neuroblastoma. So I can see why somebody can think of a Wim's tumor, because the right kidney the mass seems to push inside the right kidney. But what is typical of neuroblastoma, I'll give you the answer here, it is a neuroblastoma. What is very typical is the encasement of the vessels. You see how there is tissue in between the aorta and here in between the aorta and the spine, and this is the portal vein, and you see how these are the renal vessels, and the tissue is completely encasing the renal vessels. The liver is intact in this case. So this was a metastatic neuroblastoma. The age is very typical. As I said, median age is 22 months, but this child was barely 3 years and 3 months old, so perfect age. She did have mildly elevated HbA and VMA. She had an LDH for about 700. Now, LDH above 1,000 is considered prognostically unfavorable. Historically, her LDH was about 700, and her biology, because we analyzed the tissue for genetic changes, particularly the NMYC gene. If it is amplified, is prognostically unfavorable, but her NMYC gene is not amplified. she does have what we call segmental chromosomal abnormality, so lots of chromosomal changes, which are instead prognostically poor. So, as I said, mass which is encasing the vessels speak for a mass which is rapidly growing, and this makes it for a very challenging surgery for the surgeons. Okay. Now, this one is very different. What do you think it is? This is the child who presented with this history. The mother, this was the first child of a lovely, lovely, lovely family, and the mother told me, well, I brought him several times to GP. It had become so painful to change his nappies because his buttocks has all disappeared. He had lost so much weight. This was a 19-month-old boy when he presented with this mass. He was not playing anymore. He was just sitting on the floor, and mom just had these feelings when he changed his nappy. Okay, I see Vince tumor. Vince tumor. Everybody thinks this is a Vince tumor. Definitely, you all think it is a venous tumor. I'm really sorry. This mother was told that it was a venous tumor because, as you think, just as you think, this in this picture, and I put it on purpose, it does seem that the mass, which is all of this, is the mass, huge. So it's a huge mass. It does seem to really originate from the kidney. So this mass, this mother was told that the child had a Vince tumor. Now, the prognosis of Vince tumor is much better than the prognosis of neuroblastoma. So it was not an easy conversation to move from what they had been told, the Vince tumor, to stage 4, very aggressive neuroblastoma. This was a child with NMIC amplification and ended up having also a soft tissue involvement into peribronchial area and the malignant pleural effusion in the course of his diagnostic process. So prognostically, a much more severe type of disease. But I can see how the local radiologist has thought of a Vince tumor. And that's why you really need to have a comprehensive approach. Vince tumor very, very rarely causes a general compromisation of the child's condition. Weight loss, extremely rare in Vince tumor, very frequent in neuroblastoma. Pain, low level of energy, these are all very typical features of neuroblastoma. And HV-LVMA were very elevated. So the radiology does help you, but you do need to look at the child in a comprehensive fashion, looking at the imaging, tumor markers, clinical history, and physical examination, of course. This child is currently in remission, fortunately. So somebody has mentioned the stage 4S type of neuroblastoma. So stage 4S is a special, S stands for special, stage of neuroblastoma. It is for a child under 12 months of age, and so I wrote 1 year, but actually he was 19 months. A child under 12 months of age with a primary tumor with stage 1 or 2, and with metastasis only to the skin, liver, and minimally to the bone marrow. This mass, which historically would have been labeled as a stage 3, I'm going to talk about the staging in a minute, but this is a mass which, as you can see, crosses the midline here. So this mass would not have qualified as a stage 4S, and he had also bone disease. But what struck me of this child is that the mother had brought him to the GP at least 3 times and had been reassured by the GP, which is a shame, of course. Okay, this is a different type of tumor. This was a 15-month-old who presented with completely asymptomatic, just with a distended tummy to the GP, who then requested the ultrasound. What do you think this is? I see a hepatoblastoma, 2 hepatoblastomas. 3, 4. Okay, so initially at the ultrasound showed or described what they thought was an adrenal mass. So it was one of the examples of how difficult it is sometimes to interpret imaging. So CT scan clearly shows how this mass is actually an hepatic mass. It doesn't tell you if it is a hepatoblastoma, though, because you have a wealth of benign masses originating from the liver, starting from hemangioma, hemangioblastomas. There can be teratoma in the liver. What tells you that it is a hepatoblastoma, but I've not told you yet, is that his ASP was 146,000. So exactly. So the combination of this imaging with the ASP gave us the diagnosis of hepatoblastoma. This is a pretext to hepatoblastoma. So the staging of the hepatoblastoma is done what we call pretext, so pre-treatment extension evaluation. The liver is divided into 7 segments, and the pretext takes into consideration how many free segments there are left in the liver. There is no mass on the left. What you may think is a mass is actually the stomach. Somebody has asked if there is a mass on the left. I think this is the stomach, definitely, and this is the liver mass. Okay. So this was a pretext too, with involvement of the 5th segment of the liver. So it's an exophytic mass originating from the 5th segment of the liver and the minimal involving segment 6. And so historically, we would not have biopsied this child because ASP and imaging give you the diagnosis of hepatoblastoma. There is another malignancy which can originate frequently from the liver, which is hepatocellular carcinoma. However, this is incredibly rare under the age of 6. So when a child is 6 or older, then you start seeing mixed pathologies, and you have to consider hepatocellular carcinoma. In this age group, elevated ASP and the liver mass would be almost invariably hepatoblastoma. So the approach for this child was of upfront surgery because of the involvement of only 2 segments of the liver. The mass was resected with a partial hepatectomy. If the hepatoblastoma is more extensive, we do always do a biopsy. However, as I said, in the past we would not have biopsied, but now we try to always biopsy so that we can have a molecular investigation. We know incredibly little about hepatoblastomas. It is driven by the Wnt beta-catenin molecular pathway, but it has very few other molecular changes, and we know very little. So the purpose of the biopsy is more and more also to obtain fresh material to allow research on these tumor types. This child is doing incredibly well. Okay, what is this? Can you hear me now? Hello? Hello? Okay. Teratoma, somebody says. Rhabdomyosarcoma. Excellent suggestions. Teratoma. Yeah, germ cell tumor. Very good. Okay, I see a predominance of teratoma germ cell tumor. I would say if I think the reason to think of teratoma is because it appears so heterogeneous, which the teratoma can be. I would not commit to a specific type of germ cell tumor unless I have a biopsy, actually. So this was a germ cell tumor. We are clearly in the pelvis. And how do I know it's not a rhabdomyosarcoma? So 2 considerations. One, I happen to know that the ASP of this child was elevated, quite elevated, and again, we're back to having a global approach to the child and look at all the different aspects. Rhabdomyosarcoma is much more frequent in younger children. Now, you can have rhabdomyosarcoma in teenagers and even in young adults, but it is very rare. The third aspect, which is not shown in this picture, but it was evident in the imaging, is the ascites. Germ cell tumors very frequently cause quite large ascites and peritoneal deposits. Now, in the presence of ascites, it may be difficult to see the peritoneal deposits, but when you have a pelvic mass, or you can sometimes not see an ovarian, so you second guess that the origin of the mass is ovarian. You have an ovarian/pelvic mass with an elevated AFP or beta ACG. In this case, I would also do LDH, inhibin, CA125, CA110-9, and so forth. That really speaks for a germ cell tumor. Okay, very elevated LDH is suggestive of dysgerminoma. Elevated inhibin is suggestive of a granulosa cell tumor. Each of them would have a slightly different prognosis and follow-up. So do we biopsy or not? Again, we do have the diagnosis already, don't we? We have an imaging, we have which is suggestive. We have elevated tumor markers. Would you biopsy or would you not? Well, I would back to the consideration before. The biopsy allows you, one, to identify exactly what are the components of the germ cell tumor. If there is a component of choriocarcinoma, then you are going to be a little bit more worried, image the brain, and be a little bit more careful with the prognosis. Two, it allows you to do molecular studies and possibly submit for research. So, however, that is a very good question. Would you worry about seeding with the biopsy? So the biopsy needs to be done with following specific protocols. And there is another consideration that what you want is also to test the ascites for tumor cells, because the presence of a malignant ascites requires a more intensive treatment. So I would say, no, I'm not worried about seeding with biopsy as long as the biopsy is done correctly, and with the biopsy, I would also want to test the ascites. So a surgical procedure up front allows you to have a better understanding not only of the pathology, of the molecular features, and of the extension of the tumor. Okay. This was a patient, interesting enough, who presented and was brought to the theater for acute appendicitis. And her abdomen felt at presentation as completely hard, homogeneous. You couldn't palpate it, and there wasn't an area of soft abdomen. For some reason, an ultrasonography was not done, and it was essentially an internal problem. So she was brought to the theater with this diagnosis of acute appendicitis and acute abdomen, because it felt absolutely hard, and it was opened and closed when the surgeon saw the mass. Oh, what is this? This is a 3-year-old. The 3-year-old presented, I'll tell you the story at least, so it gives you a little bit of help. This 3-year-old presented to A&E with constipation, was sent home with laxatives and asked to come back in a week's time, was reviewed in a week later. And the child was still constipated, but actually the mother said that she had not been able to really give her the laxative. So the compliance had been poor, and the child was still well in herself, but the abdomen was more distended and had some venous reticulum. So the child was sent home again with laxatives, and there was a suggestion to come back if she didn't open her bowels, but there was no clear time frame about when to come back. So the mother came back 2 weeks later, and this is what we found. What do you think this tumor is? I can tell you the tumor markers are all negative, so AFP, beta HCG are normal. She had a high blood pressure. I see all good suggestions. Lymphoma can actually affect the kidneys, so that's very correct. Venous tumor, neuroblastoma, adrenal, Wilms. You're a little bit debating between venous tumor and neuroblastoma, which is absolutely right. I can tell you that this, so the bright area that we see here, this is the kidney, and this is the typical claw sign. Okay, this is a typical claw sign. So the kidney is completely open as an open claw, and the mass originates from the kidney. What is very unusual in this tumor is that the amount of ascites that you can see. You see how the abdomen is completely spheric, and there's a huge amount of fluid. This is all fluid. This is ascites. This child had a very extensive tumor thrombus. Tumor thrombus involving the IVC happens about 5% of venous tumor patients. It can reach the atrium, and in exceedingly rare cases can go through the tricuspid valve and reach the ventricle. It can occasionally involve the contralateral renal vessels, so in this case the left renal vessels, and it can occasionally involve the hepatic veins. So in this child, what happened was that this child had developed an extensive tumor thrombus from venous tumor, which arrived at the right atrium, involved the right hepatic vein and both renal vessels. The ascites was due to the liver, which was not functioning. She arrived with a very low albumin. The clotting was deranged. She had extensive ascites. She had very elevated blood pressure that we felt was compensatory to maintain perfusion and flow in the abdomen. But this is an incredibly rare case in a venous tumor. And just shows one of the most complicated venous tumors. It's a really rare type of disease. These patients do not require, first of all, they do not require a biopsy. So if the child is critically ill, the child needs first of all treatment. So in this case, a radiological diagnosis is perfectly acceptable. And the surgery would require a joint team of cardiothoracic surgeons who would remove and block the tumor thrombus, and the urology or oncology pediatric surgeon who would perform the nephrectomy. The age of this child was very typical, and I have to say that the initial presentation was also typical, because the initial presentation, she was well in herself, eating and drinking well. She became compromised, lethargic, and vomiting only when at the last presentation to A&E. Okay, how many MRI scans have I shown so far? I said I didn't want to see any CT scans. I think none. I've only shown CT scans. Good guide to tumor markers for kids, somebody is asking. There is not a universal guide to tumor markers. I would say for the AFP in the hepatoblastoma protocols, there is always a normal range indicated. And for VMA and HVA, you need to rely on your lab. But I would say that we would be very happy to advise on which tumor markers to do. Okay, so I haven't shown any MRI, and this brings me to a comment, which is this. There's been a huge movement towards keeping radiation exposure for children, patients, and healthcare providers as well, to as low as reasonably achievable. And this has been called the ALARA principles. So I just picked a random paper to exemplify the principles of ALARA in pediatric justification and optimization. So try to think, can I replace a CT scan typically, which exposes to quite a high radiation burden? Can I replace it with a test which does not require radiation? Like, for instance, for the abdomen, the abdominal MRI is in many cases superior and at the very least comparable to CT scan. If you're looking for lung metastasis, then you have to do a CT scan of the chest. Okay, and optimization. So limit the scan to the regions which are absolutely necessary. Don't do extensive CT scans if there is not a clinical justification. I just want to put it there as a comment. Although the logistics and practicalities may sometimes force us to use CT scan more than what we want, it's good to bear the principle in mind. And now I'm going to show you an MRI finally. What is this one? This is a 3-year-old child who presented very well in herself with a distended abdomen. The parents had felt a hard tummy. HV and VMA were normal. Blood pressure was mildly elevated. Any comments? Any ideas? Okay, it is a Wills tumor, and it is not where the arrow is pointing, which is really disappointing. It is a right-sided Wills tumor. It was a multinodular Wills tumor, so the child had multiple nodular Wills tumor and actually spared at the upper lobe. But what I'm pointing at, the arrow is pointing at, is the contralateral kidney, which showed the distal foci of nephroblastomatosis. This picture of bilateral nodules is very suggestive of this tumor, first of all, and should make us think of a possible cancer predisposition syndrome, in particular a WT1 mutation. Now, this child did not have it, but the presence of bilateral nephroblastomatosis or bilateral Wills tumor must make us think of a cancer predisposition syndrome. Now, I did not want to focus on one specifically, and this table is quite daunting, and is taken from a really good review on a clinical cancer research of pediatric cancer predisposition syndrome and surveillance. The message is more and more we are working jointly with the cancer genetics colleagues, and more we think that in a child who develops cancer at a young age is very much likely to have an underlying germline predisposition. For this tumor, in particular, we look at the WT1 gene, Fraser syndrome, Beckwith-Whitman, of course, which also predisposes to hepatoblastoma, Dennis-Rush, Wager, and so forth. But for almost each pediatric disease, there are known cancer predisposition syndromes which are associated. I will just highlight a few. So, Wills tumor, the criteria to refer a child with Wills tumor to cancer genetics are the presence of bilateral lesions, even if on one side it's only nephroblastomatosis, concomitant genitalia abnormalities, hemihypertrophy or aniridia, or and so forth. So these are the main criteria. Any child with fibromatosis will be referred. For any child with hepatoblastoma, we will be looking for an APC mutation, a mutation in APC, because if one of the parents is affected and they've transmitted actually an APC mutation, they should undergo surveillance for colorectal cancer. So there is a cascade of consequences also on the family. And then on top, there is the very famous Riefel-Menny syndrome. Like any child with adenocortical carcinoma would be referred to cancer genetics to look for TP53 mutations. This is just to give you an idea. Always look at the child as a whole. Look if there is anything into history, antenatal history, birth history, early age history, or into physical examination, dysmorphism, genitalia malformation, ear malformation, anything which makes you suspicious. Because cancer in children is a rare disease, we should always think of germline. This is not an abdominal mass, but it brings me to a topic which is very important and often a symptom which are often misunderstood. This is a chart in which the tumor, which was a thoracic tumor, but I couldn't find an abdominal image, invaded the spinal channel. And you see that this is the spinal cord completely compressed and squashed against the vertebra. This child is completely paraplegic. She presented with a very typical symptom. So she stopped walking and regressed. This was a 2-year-old child at presentation, 2 years and 3 months. when she presented, and was extensively investigated by the GP and referred for X-rays of the legs. She, at some point, a CT of the head was planned, thinking of something central, and then was counseled actually by the radiology department. She was investigated for metabolic disease. Actually, nobody thought that there could be a mass which was compressing her spinal cord. This is a chart which shows you the proportion of symptoms in patients with spinal cord compression. So 1/3 of patients will not have symptoms, but 2/3 will have symptoms. The problem is, what are the symptoms? Because it can be a motor deficit, which, as this case showed, can have other explanations other than spinal cord compression, can be pain, which often the children don't express. Even worse, can be paresthesias, which definitely a young child at 12 would not report. It could be bowel and bladder changes, again, really difficult to understand in a child who is still not toilet trained. So only a really high index of suspicion can help us with this. I just wanted to show you about 40% are abdominal masses and 40% are thoracic. I'll just go a little bit faster over here. Among the abdominal masses, 2/3 will have a very severe extent of spinal cord involvement. So 2/3 of the abdominal massive with spinal cord compression will have more than 2/3 of the spinal channel involved. That's a lot and likely to be symptomatic. This is to show you something positive. Among the children who have, the red arrow shows that among the children who have a mild or no motor deficit, so who can walk essentially, when they present, about 10% will worsen. But among those in green who have a moderate or severe motor deficit, so who are paraplegic or cannot do movement against gravity, 75% will improve. So if we catch these patients, they can improve and they can recover movement, at least in order to be functional. So we've seen a lot of masses. We've done some exercise and some practice with differential diagnosis. There are a lot of differential diagnoses, and one important concept to remember is that they are not all malignant. This is, again, I don't expect anybody to remember something like this, but it's just to show you the fact that abdominal masses in infant and childhood can very well be benign, and in particular in newborns, the most frequent renal mass is actually hydronephrosis, which is the most frequent abdominal mass in newborns. It's actually hydronephrosis, completely benign. And then you can have teratoma, you can have ovarian cyst, we can have benign cystic disease into kidney, into pancreas, and so forth. So the message is that when you see a child with abdominal mass, it does not have to be malignant. But of course, what you want to rule out is malignancy. We talked about when to biopsy and when not. Most of cases nowadays do get a biopsy, even if the radiology and tumor markers are highly suspicious. But it does give us a better understanding, the possibility of research studies, and so forth. Of course, if the child is unwell, we would not biopsy always. I'll just go through two types of tumors which are the most frequent. So the most frequent extracranial solid tumor in children is neuroblastoma, followed by Bim's tumor in the kidney. This is the protocol which is used for the treatment of Bim's tumor, which is the umbrella guidelines. And I just wanted to tell you how these tumors are actually curable. So this is the data analysis of survival for patients, Bim's tumor patients with stage 2 or 3 intermediate risk. The survival is above 90%. This is for patients, again, stage 2 or 3 with different pathology. The survival, this is on the left is the EFS, on the right is overall survival above 90%. So the survival of these children is excellent. So I see a question. Are you still biopsying nephroblastoma? The recommendation is no, unless they are under 6 months of age, because in that age group, the most frequent renal mass is actually mesoblastic nephroma, or if they are above 6, because then other pathology becomes more frequent, like clear cell carcinoma, clear cell sarcoma, or if there is something atypical, like the last nephroblastoma that we saw had an elevated ASP, and we biopsied him. So yes, we follow the new guidelines. And the neuroblastoma is a very complex disease, and I find that this slide tries to capture the complexity of it. And how do we re-stratify? The stage, the age, above or below 18 months of age, pathology, and biology. And biology is now taking over more and more a predominant role, because actually patients who have a different age have a different underlying biology. I will not go through the A to Q groups of treatment, but I'm only going to show you how, unfortunately, the survival here is very different. And even a localized patient with localized disease, if they are on top, you see the survival for patients above the age of 18 months. The survival may approach 80%. And if you have a stage 4 disease, this is on top is for age less than 18 months, but below is the survival of patients above 18 months of age with different degrees of metastatic spread. And you see how for some patients the survival is less than 10%. So we're not equally good at curing these patients, but they can be cured. And the first step is an early diagnosis, the high risk, high suspicion for an abdominal mass. So please do think of oncology, do think of masses, even if you see a patient with very aspecific symptoms. And sometimes it's not possible to achieve immediately a diagnosis, but the safety net and accurate follow-up can help. And I'm happy to thank you very much for the participation. It was a wonderful group, and I'm happy to take questions. Okay, well, yeah, I'll show the slide on the malignancies. There is a question from somebody. Give me a second. I think this has been recorded, and so I hope that it will be available for you to see again if you need. I don't think LDH is a good screening test for malignancy. LDH is heavily affected by pre-lab technical issues. It means that if your blood sample has been left on a bench for more than 2 hours, the LDH is going to be elevated just because there is lysis of the cells. And so there are important pre-analytical bias which can affect the LDH and give a false positive. But it can be helpful in once you have a suspicion, because either to orient your diagnosis, as I said, germ cell tumor with elevated LDH is likely to be a dysgerminoma. Neuroblastoma is much more often elevated LDH than Zin's tumor, and so forth. And it can be helpful as a follow-up because you will see that the LDH normalizes on treatment and then can increase again at relapse. The question about delays in presentation during COVID is interesting because we have definitely seen a lower rate of referrals, but more for leukemias than for solid tumors. Yeah, I see the question about indented abdominal mass. So first of all, where is the abdominal mass? If it is on the left iliac fossa, then it could be a fecal mass. A mass which is in a different part of the abdomen should not be labeled as a fecal mass. unless you also have a mass into left iliac fossa. I think constipation is a really difficult. It's really difficult to manage, and if it persists and there is no resolution, and you feel a mass, I would be hesitant in labeling it as a fecal mass for more than 1 or 2 weeks. Now, if you delay an ultrasound by 2 weeks and you try to aggressively manage the constipation, that is completely fine. If the constipation resolves and you don't feel the mass anymore, that's fine. That's all sorted. But I would not be reassuring and just send the parents home without a follow-up if you feel a mass and you are not sure of what it is. There's unfortunately no straightforward recipe. Okay, so there are 2 slides on malignant and non-malignant masses. So this is neonatal, and this is for older children. In the neonatals in particular, there are a lot of benign masses. Yes, BP check. I would say just be really thorough in your examination. And what I meant at the beginning by the puzzle must all fit together is that if you have aspects of the child which don't fit with the picture that you are building up in your mind, then you need to investigate them and make sure that all the aspects fit together. Any other question? Thank you for the participation. Thanks a lot. Thanks.